Good day. My name is Dr. Michael Jacklich. I'm a thoracic surgeon at Brigham and Women's Hospital in Boston and professor of surgery at Harvard Medical School. I am coming to you with this recorded webinar on March 28, 2020, in the middle of the global coronavirus pandemic, where COVID-19 cases are accumulating within my hospital. As challenging as this is, it is appropriate that we turn our attention to an equally challenging public health problem, which is the global management of lung cancer. It is my purpose to discuss the treatment of lung cancer in a way that would be the most cost-effective and impactful in resource-challenged areas of the world. I have no financial disclosures of conflict of interest in this presentation and will not discuss specific tools, equipment, or chemotherapy agents. Where you are in the world and your ability to treat lung cancer depends on the incidence of the disease, the incidence of competing diseases, what your technology is, and quite frankly, where you are in history. If one looks at the United States of America in 1984, which is of interest to me because that's when I entered the medical field, the lung cancer incidence in my country was only 84,000 new cases. It currently is about 3 times that amount. Competing causes of lung cancer, of nodules that would appear on an X-ray, included tuberculosis, and that was about 24,000 new cases. And we had no real CT scan usage and no PET scan had been invented yet. So we were using chest X-ray and sputum cytology. Our treatment was solely with an open thoracotomy. Compare that to 2020 in the United States of America. Now our lung cancer incidence is 221,000 new cases. TB's almost been eradicated from our country. It's down to 9,000 cases in a country that has 330 million citizens. Our screening technology now depends very heavily on low-dose CT scan, and our treatment includes minimally invasive techniques such as VATS lobectomy, removing only a portion of the lobe called a segmentectomy, and now increasing in popularity in my country is robot lobectomy. How do we manage lung cancer in resource-limited nations? The problem is really one of infrastructure. Many patients are recognized as having lung cancer when they have late-stage disease. This is because the early stages of the disease are frequently unaccompanied by any symptoms whatsoever. So the symptoms of shortness of breath, or coughing up blood, or fatigue, or pain in the bones, or evidence of brain metastases are frequently evidence that the patient already has stage 3 or stage 4 disease. In addition to that, many countries are faced with the challenges of inaccessible diagnosis or treatment. In 2017, 26% of low-income countries reported that they have pathology services in the public area, whereas 100% of my country has pathology services. And then greater than 90% of our high-income countries and less than 30% of low-income countries have treatment facilities. The highest smoking and lowest education are typically furthest from the urban centers, and 80% of the world population lives in low and middle income countries. There are challenges in these countries of transportation to the centers that can diagnose and treat, literacy, inadequate screening for the disease, navigation or guiding of uneducated patients through a complex healthcare system, treatment, and follow-up. Yet the need for treatment of lung cancer is growing in all parts of the world. It's dominated by the well-developed countries of Europe and North America, but it's rising, especially as tobacco use is beginning to spread into a global phenomenon. As a result of all these things coming together, when you use a CT scan or an X-ray that identifies an abnormality in the lung field, There's a difference between industrialized nations and low-resource nations. A nodule in my country that's 2 centimeters in size has a greater than 70% chance that that's a lung cancer. And so all the treatment is guided towards early diagnosis and surgical removal of the lung cancer. In the low-resource centers, there's a higher incidence of nodules that are infectious in nature. And the benefit of low-dose CT scanning has not been proven in these resource-restricted areas. But if one looks at the data, we see that the best survival comes with surgical treatment of stage 1 and stage 2 disease. Yet, before screening was initiated in the United States, 56% of patients came in with stage 4 disease, and only 15% came in with stage 1. If I am a public health minister in a resource-restricted country, I would look at this and say that my best chance to have the most positive impact in my country is to set up a program where I can find stage 1 and stage 2 disease and let surgical treatment make the best impact on controlling the disease in the country. Evidence that annual low-dose CT scan is an effective screen is increasing in its scientific basis. The benefit is relatively greater in resource-constrained areas. In the United States, we are currently screening people between age 55 and 79 with a 30 pack years of tobacco exposure. A pack year is calculated by how many packs per day a patient smokes, and there's 20 cigarettes in an American pack, times how many years they smoked, that rate of daily consumption. If a nodule is found on an X-ray or a CT scan and is believed that it's likely a cancer nodule, we push very hard to get it biopsied and staged. If, however, due to the X-ray appearance, we believe that this may be an infection and not a cancer nodule, we depend very much on repeating the scans. So what is the science? If we look at L-ELCAP, this was a non-randomized trial run in 1993, and this was the first trial of giving low-dose CT scans to screen for lung cancer. It was restricted to people 60 years of age or older with 10 pack year exposure. The important finding is that we did find early stage disease and we positively impact the survival. 85% of the cancers found were stage 1, and the patients had an 88% 5-year survival with a surgical mortality of less than 0.5%. In our largest trial, the National Lung Screening Trial, we recruited patients with 30 pack years smoking history between the ages of 55 and 74. Then we did 3 annual screens of low-dose CT versus a chest X-ray, followed by 4 years of observation. 53,000 participants were in this trial between August of 2002 and April of 2004. And this trial was stopped early because there was a 20% decrease in lung cancer-specific mortality using low-dose CTs. Here on the graphic, these first 3 years are the areas where there was actual screening, either by a chest X-ray or by low-dose CT scan. After the 3rd year, there was no screening whatsoever. So this is the observation of cancers. These are cancers that are presenting with symptoms. It is important to note that the chest X-rays found some of the lung cancers, but that the low-dose CT scan was far superior in its ability to find lung cancers. And the operative mortality in this trial was less than 1% for all the surgical resections. There's even more data that came out in January of 2020, the Nelson trial out of the Netherlands. This is the 2nd largest randomized controlled trial and included 15,792 patients. Their design was slightly different. They took patients between 50 and 75 years of age, and they didn't screen annually, but at 1 year and 3 years, and then again at 5 years. So it was every other year that they were screening. This is important information for a resource-constrained nation that may be interested in using CT scans to screen their population. You don't have to use it on a yearly basis. They followed up after 11 years of starting their trial and found that there was a difference in the survival between men and women. So they're able to reduce lung cancer-specific mortality in men by 24%, but by 33% in women. Furthermore, by doing these or biannual scans, the overdiagnosis rates dropped from 19.7% in the National Lung Screening Trial to 8.9% at 11 years. One of my roles has been working with the American Association of Thoracic Surgery to help form these screening guidelines. And I can break this down to a resource-constrained country to this recommendation, that if an X-ray or a CT scan finds a nodule that's a very, very small nodule, 6 millimeters or less, that is counted as a negative scan. And whether you're doing annual scans or you're doing scans every 2 years, no change should be made for that patient other than the scan in another year or two. If you're in an intermediate range where it's found between 1 centimeter and 6 millimeters, and yes, the CT scan can find nodules that are that small, then the scan is repeated sooner than the usual planned time, typically in 6 months. In this way, the repeat scan can differentiate between an infection and cancer. The cancer would be expected to increase in size at the calculated rate of a tumor doubling time of approximately 120 days, and then an infectious nodule would be expected to be more stable. Finally, if there is a nodule seen on the CT scan of the chest X-ray that's greater than 1 centimeter, the probability that that is a cancer dramatically increases, and you should consider biopsy or surgically removing that spot. If we follow just one highlighted area of this algorithm for the AATS, then if a new nodule is found on a scan that was not there on a previous scan, but we suspect that it is inflammation, you repeat that scan in a shorter period of time, between 2 and 6 months. If it is persistent or enlarging, then the suspicion of lung cancer is there, and you should go to surgical excision or biopsy. I have eliminated this step of using the PET scan in a resource-constrained area. The reason why is that in my nation, the purchase of a CT scan is approximately $350 US, whereas the purchase of a PET scan is approximately $7,000 US, plus there's the difficulty of getting the radioisotopes involved in the PET scan. I'm working under the assumption that most resource-constrained areas will not have the technology of a PET scan available to them. However, using this algorithm with CT scans, I believe, is a highly effective strategy. Now, in addition to this, deciding who should get a scan, in addition to the tobacco exposure, it depends on other variables, including your family history. So to bring these into play, there are numerous web-based calculator models that are available for anybody to use who has internet access. One demonstration of this I'm going to perform for you now. I'm going to step out of this and go to my Google search, where I'm going to put in the AATS lung cancer screening. And here it is, lung cancer screening AATS. You can click on this, and we'll begin lung cancer assessment. Are you male or female? I'm going to suggest that we're calculating for a female age 61 who has no education. I'm assuming that she is 5 foot 2 inches, or we can go to the metric system. I'm assuming that she's 140 pounds. I can calculate the BMI of this patient. This patient has had no previous x-rays. They do have a brother who had lung cancer at age 50. This person currently smokes about 1 pack a day. I'm sorry, they started smoking when they were 15, and they're smoking 1 pack a day, which is 20 cigarettes. They have no asbestos, no emphysema, no pneumonia, and no prior malignant tumor. And now here's their risk of developing lung cancer over the next 10 years. So this patient has a 1% over the next year, but approximately a 5% over the next 5 years, and 10% over the next 9 years. So anyone who has over a 2% risk over the next 5 years is somebody who we would choose to screen. I'm now going to go back to the presentation. Lung cancer staging uses the TNM staging system. The goal of this public health policy that I'm endorsing is to find stage 1 or stage 2 disease. Stage 1 disease is tumors that are less than 3 centimeters in diameter and is shown on the left side of this illustration. So it's just a tumor without any evidence of lymph nodes, whereas stage 2 is the same lung disease but now with a involved lymph node. We believe that everybody deserves a diagnosis and staging. It's one of the basic caveats of our treatment plan at our cancer center. So how do you make a diagnosis? Even in a resource-constrained country, bronchoscopy with washings and biopsy should be available at the major teaching centers. A CT-guided needle biopsy is also a basic level of technology that should be available, again, at the academic centers. Staging typically requires either CT scan and EBUS or CT scan and cervical mediastinoscopy, and I will review these topics to explain them. Bronchoscopy and EBUS are frequently done at the same time. So somebody's been identified as having an abnormality on their CT scan or their chest X-ray, but no diagnosis has been obtained. To the left, the surgeon is passing a bronchoscope, the surgeon or pulmonologist is passing the bronchoscope and can obtain washings and brushings of this area in order to get cells that can be seen by the pathologist. It is not infrequent, even in this country, that those slides have to go to a central repository for pathologic review at a major academic center. There is technology where an ultrasound probe is on the end of the bronchoscope and a needle can be passed through the wall of the bronchus, guided by the ultrasound images, directly into a lymph node to help stage those lymph nodes. The purpose is to identify those patients who have stage 3 disease and thus are unlikely to benefit from surgery, from those who have stage 1 or 2 disease who should be treated with surgical resection. Our workhorse for staging the lymph nodes in the 1980s was cervical mediastinoscopy. It's combined in the same operative procedure as the bronchoscopy. The neck is extended and a small incision is made just above the breastbone. The surgeon passes his finger through that skin incision and underneath the breastbone in order to palpate the nodes down in the central part of the chest. There's a plane just in front of the trachea that allows insertion of a device called the Carlin's mediastinoscope. This is the mediastinoscope being inserted through the skin incision, and all these lymph nodes that are down in the middle part of the chest are identified on the American Thoracic Society's lymph node map. In this map, any node that has a single digit, ranging from 1 to 2R, 2L, to 3, 4R, 4L, 5, 6, 7, 8, or 9, are considered N2 disease, thus stage 3A or stage 3B. If the lymph nodes are clean and they're typically biopsied from 4R, 4L, and 7, then it is not stage 3 and will be either stage 1 or stage 2. Surgical resection then is reserved for those patients with presumed lung cancer no metastases on the CT scan, and a CT scan of the chest will show you the other lung, it will show you the liver, it will show you the kidneys, it will show you the adrenal glands. There are no involved mediastinal nodes on mediastinoscopy, and the patient is strong enough to withstand surgery, then surgical resection should be performed. In the 1980s, we were very dependent on thoracotomies. This is how I was trained. They are large incisions. They're incisions that go from the back of one rib to the front of a rib. They give excellent exposure. They're certainly safe to remove lung cancer off of the arteries that come into the lung from the heart. However, the deaths are usually due to the size of the incision and the function of the age. You can see that there's quite a bit of tissue destruction and pain that can be associated with this type of operation. Furthermore, the risk of not surviving the operation is a function of how old you are when you have it done. So less than 60 years of age, 99% of patients survive it. But if you try to do this on somebody over the age of 80, only 9 in 10 will survive, and 1 in 10 will succumb to complications from the operation. So we have evolved in the United States to emphasize more minimally invasive approaches, and that's how we've dropped those expected mortalities that was done in the screening trials. Initially, we only did lobectomy from the 1930s to the 1990s. The minimally invasive techniques became widely available in the early 1990s. In 2013, the American College of Chest Physicians began recommending video-assisted thoracoscopic surgery based on retrospective data, and in 2016, a nice randomized control trial identified less postoperative pain and quality of life with the video-assisted thoracic surgery. Now, video-assisted thoracic surgery is the gold standard for stage 1 and 2 disease, and robot lobectomy is becoming comparable, although I don't emphasize robot lobectomy in this talk due to our desire to come up with a strategy for resource-constrained areas. This is what VATS surgery looks like. It has also been referred to as chopstick surgery. You need the equipment in order to do it. Much of the equipment is can be re-sterilized and is not disposable. The cameras have to be purchased, but one of my interests in this back in the 90s was looking at this specifically at the most frail population, and that was our elderly patients. So in a study that I published in Chest in '96, looking at nearly 300 patients, we found that the overall mortality was less than 1% for this population using the minimally invasive technique. This should not be surprising. You can see that there's far less tissue destruction to the chest wall by doing this sort of minimally invasive technique and without impairing the function of the ribs. It's far safer. So the issue is the rib spreading. So in this study of CALGB, it was specifically defined that a VATS lobectomy involved no rib spreading, and with 111 patients in a randomized observation trial, there was a 30-day mortality of only 2.7%. And then this trial also standardized the approach to what is involved in VATS lobectomy. This is published under the first author of Scott Swanson. We also looked at what is the 30-day mortality after lobectomy in the United States for elderly patients who would be available for screening, and we can see that even in the United States, in the modern era, 2005 to 2012, those who had an open thoracotomy had a 3% operative mortality, but those who had minimally invasive surgery only had a 1% mortality. Now, another evolving area, especially if you have a CT screening program, is you can do more organ preservation and take less of the lung tissue. So to understand this, it's important to become familiar with the terms. This model is showing you the 5 lobes of the lung: the right lower lobe, the right middle lobe, the right upper lobe, the left upper lobe, and the left lower lobe. A wedge resection means that you cut like a pie wedge out of that portion of the lung. It is the same idea as a wide local excision of a breast tumor. So almost all of the lung function remains. Usually you're taking about 1 to 2% of the lung function. And this only makes sense really for lung cancers that are in the range of 2 centimeters or less. We have a growing experience with segmentectomy. This is becoming very popular in the United States, especially with screening methods that are finding lung cancers that are around 1 centimeter. There are 3 segments within the right upper lobe, 2 within the middle lobe, 5 within the lower lobes, and thus you're preserving more lung tissue. So if you did a single segmentectomy, you're taking about 5% of the lung. A lobectomy is a very traditional surgical resection for lung cancer. In this model, the right upper lobe has been resected. That's 3 segments or 15% of the lung tissue. And then finally, the most dramatic for the central tumors is the pneumonectomy. The pneumonectomy is the loss of an entire lung. In this case, it would have removed 55% of the lung tissue. So let's talk about the practicalities. The CT scan in the United States is about $350. If you're using that to identify early stage lung cancer and a mediastinoscopy in order to stage the lymph nodes, then you wanted to get into the VATS method, then you have to purchase the VATS instruments. Now, scopes were on sale yesterday on eBay when I looked for under $5,000. It's not enough just to have a scope and a light source. You do need a backup light source, and there is a learning curve. What do you do when the VATS incision is not working out the way that you want? You're in danger of going into a precious blood supply for your patients, and there's a long anesthesia time. These would be indications to change from an attempted VATS to an open thoracotomy. I will say that in the escalation of an operation from a VATS to a thoracotomy, we frequently can limit the size of the thoracotomy with the scope still in assisting us, and the learning curve can really be quite steep. Additionally, there are more and more fellows that we see here in the United States, and I know also in England, that are interested in returning to their home environments, even though it's resource constrained, and using the techniques that they're finding in the modern U.S. academic centers to bring back to their home countries. CT scan for a non-contrast scan in the United States is $350 US. PET scans, I think, are prohibitively expensive at $7,000 United States dollars, and thus is really not practical to plan to include in your intervention plan. It's important that you identify people who are strong enough to undergo the operation. I don't think that that's a problem in resource constrained areas of the world. I think that the workforce is really quite strong in those areas. You do have to perform a history and physical and identify and optimize any other illnesses. You do need some method of measuring what is their strength and judge their strength. The pulmonary function tests are helpful. Spirometry is easily obtained in the office. It is blowing through a tube, and there are portable spirometry tests. I don't think that it's absolutely necessary if you're operating on strong people, but it is part of identifying that person is at the edge of what you can hope to help if somebody has severe impairment in their pulmonary function test. I did not include any of the more advanced tests that we have available to us in the industrialized nations, as I really don't think that they're practical, again, in a resource-confined area. What if it's not stage 1 or 2 disease? Well, stage 4 disease is typically going to require either no treatment or palliative treatment for symptoms. Stage 3 disease is a disease that in this nation and the major academic centers will be resected after treating with neoadjuvant chemoradiation therapy. But even in our community hospitals, this is not the standard. In our community hospitals, they'll be treated with what's called definitive chemotherapy and radiation and do not come to surgery. So what is the minimum for a resource-confined area? The way to get the most change is through a prevention program that looks for tobacco control and smoking cessation. There's no doubt that this is the single most important public health step towards controlling lung disease. After this, the next most effective step is to come up with a lung cancer screening program. And it doesn't have to be the entire population, but either using those web-based risk calculators or coming up with a standard policy of screening once a year or once every other year like the Nelson trial did, setting what your age parameters should be and what your tobacco exposure should be. This is a highly cost-effective program. And then, so a minimum that you need for a successful program, in my opinion, is you need a CT scan, you need a way to measure your functional status, you need either EBUS or staging cervical mediastinoscopy. I put staging CMED up here because I think it's cheaper than running an EBUS program. And then resection, and you want at least access for some academic center in your nation to have the minimally invasive techniques that then can develop the techniques, teach a generation how to do those techniques, and then have it populate out to the more secondary hospitals from the academic center as the next step. And then I think the emphasis needs to be on the treatment of stage 1 and 2 non-small cell lung cancer. And then only if resources allow do you then develop the next step, which is chemoradiation for stage 3A disease in a multidisciplinary management. I want to thank you all for your time listening. Greetings to you from Boston. Even though we are in the midst of the pandemic, I thank you again for the collaboration that we've all shared and the support that we've all given each other in these challenging times. Thanks.
Thank you, Dr. Jakulich, for your time and for your great lecture today. At this point, if anyone has any questions, please feel free to share them now.
Yeah, thank you, Professor Jakulich. That's really great. I have a question about the, can you possibly comment on surgery versus SBRT for lung cancer?
Yes. So SBRT is a locally ablative therapy directly on the primary tumor, and by its very nature does not cover the regional nodal beds that drain that tumor. It is a very effective technique for people who are not strong enough for surgery and clearly has lower risk than an operative procedure. Its success depends on how big the tumor is and also where the tumor is located. There are some areas where SBRT can be difficult that are not difficult for surgery, such as directly underneath the rib or in direct location where it's adjacent to the pericardium. The results at 3 years are clearly comparable to what surgery would be, but there is some evidence that the long-term survival is better with lung cancer, and it may be that the lung cancer is actually staging more accurately by getting lymph nodes out and identifying those that had cancer within the lymph nodes, so they could have gotten some additional therapy. So when we're doing the studies comparing SBRT and surgery, if they had a positive node, we usually exclude them from the cohort that's being compared to the SBRT. Does that make sense?
Yes. No, thank you so much. Yeah, that makes sense.
But it's a good choice. It is a good choice.
Do we have any further questions for Dr. Jakulich?
Yes, hello, Dr. Jakulich. Thank you for your presentation. Please, I wish to know, is there any specific number of nodes when you do the EBUS and it come back negative, but let's say you did the PET scan, it's showing some reaction around the reaction around the node, that the only EBUS node that you could have showed negative, and though the PET scan is showing some still reactive node, and you are not in a setting of infection. So up to which level will you be comfortable to say those nodes were negative, especially when you are on the borderline kind of staging, like on the 3A? I don't know if
that's really an outstanding question. The EBUSs are so easy and have so many advantages over the mediastinoscopy that 5-6 years ago, we really thought that they were going to completely replace mediastinoscopy. So the EBUS can easily get the 4R, the 4L, and the 7 node to stage the mediastinum the way the mediastinoscopy did. But then it can go further out and get N1 nodes right at the right upper lobe takeoff or over the bronchus intermedius or at the junction of the left upper lobe and the left lower lobe. And it has access to more nodes than cervical mediastinoscopy does. So for that reason, it can be really accurate. Now, if you have a PET scan and the PET scan suggests the node's positive, and then you have the EBUS and the EBUS says no cancer in the node, the worry is that you missed it. So the analogy that we give our patients is you're trying to biopsy a pepperoni pizza and you got back pizza as the diagnosis because you didn't actually hit one of the pepperonis. So if you have access to a surgeon who is skilled at mediastinoscopy, that patient is going to mediastinoscopy here, because we do have a big experience with mediastinoscopy. And if it is positive, that's 3A disease. That changes everything about success for surgery. If you don't have a skilled mediastinoscopist, I think at the very least, you should consider repeating the EBUS. Now, if you have 2 EBUSs that both say that that PET avid area is negative, and you don't have access to a mediastinoscopist, I think that's as good as you can get. And then I would go ahead and say, we believe the node's negative, and the patient's going to go to surgery. And then the very first thing we ask the surgeon to do is, could you please get that whole node out and potentially send it for frozen? Or you've just, it's an imperfect world, you did the best you could, and you went ahead and did the surgical resection.